Okay. So, hello everyone. Namaste. Salam alaikum. Sat Sri Akal. And welcome everyone to, this CCI webinar. I must say this is one of the places where everyone is treated as family. And this webinar is something which remarkably has been ongoing for such a long time. Lots of people to thank at the outset. I would just like to thank Dr. N.H. Krishna, sir, Dr. Atri, Dr. Anil Maske, Dr. Ashish Dubey, Dr. Vijay Kumar Chenan Chetty, so many people behind the stage who are working day in and day out, to get these webinars live for every single person. And today, I must admit, I am slightly out of my comfort zone. When I was first contacted by Dr. N.H. Krishna, sir, for today's topic, I was slightly taken aback, because this is one of the topics which everyone assumes that we all know, but unfortunately, that is far from reality. We all know that there is an issue, of course, with the nose, but it is something which I must say is always on the back burner. So thank you so much, N.H. Krishna, sir, for giving this topic. Today's webinar is all about nasal blockage. What are the types, pathophysiology, definition, mechanisms, what should be the differentials? There is so much to discuss. And I'm so happy that I am the moderator in this session and I'm not one of the panelists. So my panelists definitely have got a tough job, to do. We've got one more brilliant concept. We've got 3 pulmonologists and 3 ENT surgeons today. So the pulmonologists are Dr. Gurpreet Singh, sir, Dr. KP Singh, sir, and my brother, Dr. Ravi Dosi. And of course, from the ENT surgical point of view, we've got Dr. Farmida Aman, we've got Dr. Seemab Shaikh, and we've got Dr. Abhishek Shrivastava. So truly a proper representative all the way from Ludhiana to Bangalore, covering pan-India like CCI has already done. So the flow of today's webinar is we will be having 2 presentations. The first presentation is going to be by Dr. Farmida Aman, in which she's going to talk about rhinitis, the basics of rhinitis, what are the types, and she's going to touch base with the basics of inflammation of the nasal cavity. And this will be followed by Dr. Gurpreet Singh, sir, who will give us an overview of area guidelines, which is allergic rhinitis and its impact on asthma. Again, something which we always keep on the back burner. So both these people will do their presentation, which will be followed by a lovely discussion with all the panelists. So Dr. Farmida Aman, the mic and the stage is all yours.
A very good evening to the esteemed panelists and members of the CCI. Thank you, Dr. Kapil, for the wonderful introduction. I'd also like to thank CCI for giving me the opportunity to be part of this August panel. Today, I'll be speaking on rhinitis, its types and their management. But before I embark upon rhinitis, I'd like to dwell a little upon the functions of the nose and the relevant anatomy of the nasal cavity. So the main functions of the nose are respiration and olfaction. Along with that, it also humidifies and warms the inspired air, and it removes the minute airborne particles that may enter the airway, thus preventing them entering into the lower airway. It also facilitates drainage from the adjacent paranasal sinuses. The paranasal sinuses are mucus-lined cavities, air-filled cavities, which surround the nasal cavity. These are the maxillary sinuses, the ethmoidal sinuses, the frontal sinuses, and the sphenoid sinus. The nasal cavity is divided into 2 parts, 2 cavities by the nasal septum, which is composed of cartilages and bones. The nasal cavity, it communicates with the external environment with the anterior nares and the nasopharynx through the posterior nares. We will dwell upon the lateral wall of the nasal cavity, in which the paranasal sinuses drain into. So the lateral wall of the nasal cavity, it consists of 3 bony projections covered with nasal mucosa. These the first one is the superior turbinate, this is the middle turbinate, and this is the inferior turbinate. Inferior to the superior turbinate is the superior meatus. Here, the posterior ethmoidal sinus drains. The inferior to the middle turbinate is the middle meatus. This provides the drainage site for the sinuses of frontal sinus, maxillary sinus, and the anterior ethmoidal sinuses. And together they form the osteomeatal complex. Inferior meatus is the site for drainage of the nasolacrimal duct. Above the superior turbinate, we have the sphenoethmoidal recess through which the sphenoid sinus drains. So now we come to the main topic of rhinitis. Rhinitis is defined as the inflammation of the mucosal lining of the nose characterized by one or more of the following symptoms, which are nasal congestion, rhinorrhea, pruritus, and sneezing. It is an umbrella entity that includes various different subtypes. It causes a lot of morbidity and is a financial burden for the healthcare systems worldwide. It can also pose to be a risk factor for other conditions like sinusitis, otitis media, asthma, learning impairment, behavioral changes, psychological impairment. The types of rhinitis the three major types of rhinitis are allergic rhinitis, infectious rhinitis, and non-allergic, non-infective rhinitis. Non-allergic and non-infective rhinitis has various subtypes as well. Coming to allergic rhinitis is an atopic disease characterized by symptoms of nasal congestion, rhinorrhea, nasal pruritus, and sneezing. It is an IgE-mediated immune response against inhaled aeroallergens. It is found in 25 to 30% of patients. It is also very high in pediatric population. It is associated with significant morbidity, loss of productivity, increase in healthcare cost. It can be classified into seasonal, perennial. 20% of patients fall into the seasonal variety, 40% fall into the perennial variety, whereas both seasonal and perennial may be seen in 40% of patients. It is associated with other conditions like allergic conjunctivitis, productive cough, eustachian dysfunction, and chronic sinusitis. Allergic rhinitis also increases the risk of allergic asthma. 40% of allergic rhinitis patients suffer from allergic asthma, and 40% have increased airway hyperresponsiveness. Coming to the etiopathogenesis, allergic rhinitis, the allergic response here is classified into two types. The first is the early phase response, and the other is the late phase response. In the early phase response, it is an IgE mediated response in which mast cell degranulation takes place and leading to release of inflammatory mediators like antihistamines. This induces sneezing and rhinorrhea in patients. While leukotrienes and prostaglandin, which is released, it influences upon the blood vessels, causing congestion in the nose. The late phase reaction, it takes place around 4 to 6 hours later. And here cytokines influx of cytokines occur, and there is infiltration of eosinophils, T lymphocytes, and basophils into the nasal mucosa, leading to congestion and edema of the nasal mucosa. So, the causative agents for allergic rhinitis are allergens which are aeroallergens like tree, weed, and grass pollens, house dust mites, pests, and molds. House dust mites tend to be the most common allergen that leads to perennial allergic rhinitis. The diagnosis of allergic rhinitis, history is the mainstay of diagnosis of allergic rhinitis, in which questions pertaining to types of symptoms, time, duration, place, family history is taken. On examination in allergic rhinitis patients, we may see rhinorrhea, which is clear, and edematous nasal mucosa. Sometimes hypertrophic turbinates may be present. In case of sinusitis, there will be tender sinuses. Also, sometimes middle ear effusion may be present. Also, we should also take the history of concomitant asthma in these patients. To come to an objective diagnosis, we have to do serum allergen-specific immunoglobulin E test. Skin prick test is taken to be gold standard for diagnosing allergic rhinitis. Also, intradermal allergy testing may be done. And here I would like to speak about local allergic rhinitis. Here, in this entity, nasal production of specific immunoglobulin and E antibodies are seen locally. There is absence of atopy, and it is found in 40% of non-allergic rhinitis patients. Here, the clinical symptoms are almost similar to allergic rhinitis, but there is no symptom of any systemic allergy. There is a local production of specific immunoglobulin E antibodies, and if we examine the nasal fluid, we find increased eosinophils, mast cells, T lymphocytes in the nasal fluid. These patients also show a positive response to nasal allergen provocation test, and it is important because over time it can progress to allergic rhinitis. Management of allergic rhinitis includes avoidance measures, but avoidance measures are easier said than done. So pharmacotherapy happens to be an important part of management of allergic rhinitis. In mild cases, only antihistamines may be administered. Topical decongestants may be administered in severe nasal congestion, but not more than 7 to 10 days. Intranasal corticosteroids alone or with antihistamines may be administered in cases which are persistent and has severe nasal blockage. Leukotriene receptor antagonists may be considered in difficult to treat cases and with cases with severe nasal blockage. Mast cell stabilizers have very limited role in management of allergic rhinitis. Sodium chromoglycate, though, may be used in children who are less than 2 years. In case of refractory cases where pharmacotherapy is not working, and in persistent, moderately severe cases, we can also go for allergen immunotherapy. Now, coming to the next type of rhinitis, it is infectious rhinitis, which is also known as acute viral rhinitis. It is a part of the common cold syndrome. This is usually self-limiting, and treatment is only symptomatic. Antibiotics are only administered in cases of superadded bacterial infection. Next comes a non-allergic, non-infectious rhinitis, which includes drug-induced rhinitis, which may be due to aspirin, NSAIDs, other NSAIDs or ACE inhibitors, OCPs. Rhinitis medicamentosa may result from overuse of nasal decongestants. There is occupational rhinitis, where patients may have allergy to airborne agents in workplace like wood dust, laboratory animals like rat, guinea pigs, cranes, etc. Hormone-induced rhinitis is seen in puberty, pregnancy, during menstrual cycle. Here, inflammation of nasal mucosa is related to increase in estrogen in the body. Gastritary rhinitis is the watery or mucoid rhinorrhea that can ensue following ingestion of hot and spicy food. Now, coming to non-allergic rhinitis with eosinophilic syndrome. Here, this syndrome has symptoms which are similar to allergic rhinitis, like rhinorrhea, sneezing, pruritus. And in this case, anosmia is very prominent. But in these cases, there is no evidence of allergy. Here, there is a chronic non-specific liberation of histamine and chronic eosinophilic nasal inflammation with development of nasal micropolyposis and polyposis. Nasal cytology may show more than 20% of eosinophils in these cases. Treatment includes administration of intranasal corticosteroids along with second-generation antihistamines with or without leukotriene receptor antagonist. Idiopathic rhinitis, which is also known as vasomotor rhinitis, is the most common non-allergic rhinitis, comprising 71% of all non-allergic rhinitis. It is caused by dysregulation of sympathetic, parasympathetic, and nociceptive nerves. It can be triggered by strong odors, cold air exposure, alcohol, change in temperature, change in humidity and barometric pressures. It is found in 20% of population in industrialized countries and is common between 30 to 60 years of age and more common in females. The symptoms are similar to allergic rhinitis, which are rhinorrhea, nasal congestion, sneezing. In examination, we may see boggy edematous nasal mucosa. So the diagnosis of idiopathic rhinitis, it is a diagnosis of exclusion where it has to be differentiated from infectious rhinitis and allergic rhinitis. The treatment includes topical intranasal corticosteroids and topical anticholinergics like ipratropium bromide may be given. Antihistamines may also be given. Video neurectomy may be considered in case of refractory cases. Atrophic rhinitis is a chronic degenerative nasal disease characterized by progressive atrophy of the nasal mucosa. The signs and symptoms may include formation of nasal crust. There may be an offensive odor. There may be purulent discharge. The patient will complain of nasal blockage. On examination, we may find that the nasal cavities has expanded and they have become roomy. These are classified into primary and secondary type. Primary is has a spontaneous onset and it progresses very slowly and it may be associated with Klebsiella ozonae. Secondary atrophic rhinitis occurs following extensive nasal surgery where there is extensive nasal mucosal damage. Radiation therapy also may cause it, and granulomatous diseases may cause secondary atrophic rhinitis. Management generally includes nasal douching with sodium bicarbonate, glucose glycerin drops. Antibiotics may be necessary like ciprofloxacin. Now there's nasal submucosal injections with autologous fat and platelet-rich plasma is also done. Surgical management is generally done to restore nasal mucosa, decrease size of the nasal cavity, and improve vascularity of the nasal mucosa. With this, I come to an end of my presentation. These are my references. Thank you very much.
Good evening, friends. Thanks, Dr. Kapil, for nice introduction. At the outset, I am thankful to CCI for giving me an opportunity to be a panelist in today's webinar. After Dr. Farmida's lucid talk on rhinitis and its overview, I will be speaking about area guidelines, that is allergic rhinitis and its impact on asthma. So the agenda is why ARIA, new classification of rhinitis, what it is, importance of nasal inflammation, treatment based on evidence, and impact of rhinitis on asthma. So we will be talking about these things in next few minutes. There is a need for guidelines in the management of allergic rhinitis, as allergic rhinitis is a global health problem which affects 5 to 50% of the population, which is enormous. And its prevalence is increasing by each decade. Although it is not usually a severe disease, that is, it does not cause too much of morbidity or mortality, but rhinitis alters social life and affects school performance and work productivity. There is also a substantial cost on treatment of rhinitis, as well as in terms of abstinence from work. Implementation of guidelines will improve the condition of patients with allergic rhinitis. Coming to new classification of rhinitis, the earlier classification of seasonal and perennial allergic rhinitis has been changed to intermittent and persistent allergic rhinitis. So instead of seasonal and perennial, it is classified as intermittent and persistent. So these can be correlated with the disease like bronchial asthma also, where also we have mild, intermittent and persistent asthma. So intermittent or seasonal is directly related to exposure to outdoor allergens like pollen. Whenever there is an increase in pollens in the air or any allergen, the symptomatology will increase. In comparison to that, the persistent or perennial is related to indoor allergen like house dust mite. You can see that there is a minimal persistent inflammation at all the time, and whenever there is increase in mite allergen in the environment, the inflammation and as well as the symptomatology will increase. So you can see here area classification, that the intermittent is when the symptoms are less than 4 days per week or less than 4 weeks in a year. Persistent is when the symptoms are more than 4 days per week and it is for more than 4 weeks. So intermittent and persistent is divided into the duration of this symptomatology. Again, it is divided into mild or moderate and severe. Mild is when the patient is not having that troublesome symptoms. The patient is having normal sleep, no impairment of daily activities, sport or leisure, and normal work and school. So these are the patients who are having mild symptoms, whether it is intermittent or persistent. And these patients actually do not need much of treatment and they are okay with treatment taken from over-the-counter drugs like oral antihistamine or intranasal antihistamines. The problem is with the patients who are having moderate or severe symptoms, who are having one or more of the things like abnormal sleep, impairment of daily activities, sport, leisure, abnormal work and abstinence from school, and they are having troublesome symptoms. So we will be concentrating more on treatment of these patients who are having moderate to severe, intermittent or persistent symptoms. So these patients can be having intermittent symptoms or persistent symptoms. So just like in bronchial asthma, we have objective parameter like pulmonary function test in the form of reversible FEV1 or spirometry. Here in allergic rhinitis, we have a visual analog score. So we tell the patient to label their symptoms according to their symptomatology. That is, whether the symptoms were troublesome or not for last 24 hours in the form of nasal symptoms like congestion, itching, secretion, or sneezing, or it can be ocular symptoms like redness, watery eyes, or itching. And the physician will, as per the points given by the patient, it will be labeled as uncontrolled if the number is more than 5. 2 to 5 is partially controlled and less than 2 symptoms are fully controlled. So as per the patient's controlled symptoms, the treatment will be stepped up or stepped down, just like in bronchial asthma. So you can see these symptoms ranges from congestion like 0 to 100. 0 is there is no congestion and 100 or 10 is complete obstruction at day and night. Rhinorrhea 0 means dry nose all the day and 100 is continuous secretion. Itching, no itching is 0 and 10 or 100 is persistent itching which disrupts everyday activities. Similarly, sneezing, no sneezing is given a point of 0 and 100 or 10 is persistent sneezing whole of the day and night that disrupt normal functioning. So it is very easy and patient can actually give you a symptomatology about his how much it is controlled with the treatment. So before labeling the patient as allergic rhinitis, as Dr. Farmida has beautifully explained, that we have to do a differential diagnosis of allergic rhinitis. That is, the patient is not having any other etiology of rhinitis like vasomotor rhinitis, infectious rhinitis, cerebrospinal fluid leak, non-allergic rhinitis with eosinophilia syndrome. Similarly, chemical rhinitis, rhinitis of pregnancy, any drug-induced rhinitis, that is, you rule out any exposure to these drugs like NSAIDs, ACE inhibitors. Paradoxically, nasal decongestants can cause rhinitis. That is why it is recommended that patient should not use nasal decongestants for a longer time. It is used only as a rescue therapy for 7 to 10 days. You rule out any autoimmune process like or vasculitis rhinitis, granulomatosis, polyangiitis, sarcoidosis, etc. Also rule out nasal polyposis or nasopharyngeal neoplasm. Coming to importance of nasal inflammation, Dr. Farmida has beautifully explained about persistent inflammation in response to allergen, and I will not go into detail. Coming to treatment based on evidence, which is the main thing about area guidelines. The most important thing is how we can treat this patient at a nominal cost. So cost is definitely a factor. Allergen avoidance is theoretically looks like it may help, uh, but most of the time it is not helpful. That is, you can't avoid pollens or house dust mite all the time. Patient education about allergic rhinitis is very, very important. That is, patient should be knowing that what is the disease process. He must be knowing about the inflammation, and so that he can be compliant with the treatment. Pharmacotherapy is important, and in this, it is important that these drugs should be safe, effective, easy to administer. Just like in bronchial asthma, we use anti-inflammatory drugs. Similarly, in allergic rhinitis, the main treatment is intranasal corticosteroid. We will be talking about these in coming slides. In patients who do not respond to pharmacotherapy, the other treatment options could be a immunotherapy, which is specific immunotherapy. It can be subcutaneous or sublingual, but it needs a specialist prescription. This may alter the natural course of the disease. The newer treatments like anti-IgE or biologicals like omalizumab is also available. We will be talking about those also in coming slides. So the recommendations are based on evidence. I will not go into detail, but everyone knows grading A, B, C, D, depending upon whether it is RCT meta-analysis or whether it is expert opinion. So we have different drugs or pharmacological drugs available for our patients, whether these are oral antihistamine. And nowadays we have newer generation oral antihistamines available, which are non-sedating or less sedating. Intranasal antihistamines are available like azilistine. Intranasal corticosteroid, as I said, they are the backbone of treatment, and all these are having grade A recommendation. Antileukotrienes like montelukast can be used in children or in patients who are also having bronchial asthma. But again, there is a black box warning from FDA about neuropsychiatric symptoms related to montelukast. Subcutaneous specific immunotherapy, sublingual or nasal specific immunotherapy, the grading is A. Allergen avoidance, as I said, is grade D only. So these medications can help these patients in alleviating the symptoms of sneezing, rhinorrhea, nasal obstruction, nasal itch, and eye symptoms. Like antihistamines, whether these are oral or intranasal, they alleviate symptoms of sneezing, rhinorrhea, nasal itch, but they do not benefit patients who are having nasal obstruction. Corticosteroids, especially intranasal corticosteroids, are helpful in alleviating all these symptoms of sneezing, rhinorrhea, nasal obstruction, nasal itch. That is why these are the preferred treatment. Intranasal hormones can be helpful to some extent in alleviating symptoms of sneezing, rhinorrhea, nasal obstruction, and nasal itch. Patients who are having eye symptoms can have some benefits with intraocular hormones. Decongestants, intranasal, like xylometazoline, they can alleviate symptoms of nasal obstruction, but these should be used only as a rescue medication, as these can be habit forming and these can cause actually paradox rhinitis. So these drugs should be avoided. Anticholinergics like ipratropium bromide intranasal can be used to alleviate symptoms of rhinorrhea. So again, this is very, very important. Same thing, this drug we use in bronchial asthma also. Antileukotrienes like montelukast can prevent rhinorrhea, nasal obstruction, and eye symptoms to some extent. So this is the chart which tells you about first diagnosis of allergic rhinitis. We should always be careful that when we are diagnosing patients with allergic rhinitis, we should also check for whether these patients are having concomitant bronchial asthma. So we can treat both the allergic phenomena or inflammatory phenomena with the drugs. So especially in patients who are having moderate or severe persistent rhinitis, 40% of these patients could be having bronchial asthma. So first of all, we have to divide these patients into whether they are having intermittent symptoms or persistent symptoms. And then based upon their severity, we treat them. If the patient is having only mild symptoms, these patients can be just taking over-the-counter drugs like H1 blocker, antihistamine drugs, newer generation, or intranasal H1 blocker. These patients may be using oral decongestants or leukotriene receptor antagonists. These patients hardly come to specialists for their problem. In patients who are having moderate to severe intermittent symptoms or mild persistent symptoms, these patients are those patients who are having ongoing inflammation, and these patients will benefit maximum with intranasal corticosteroids. So patients who are having moderate to severe intermittent symptoms or mild persistent symptoms, they should be put on intranasal corticosteroids for maximum benefit. Other drugs which can be used are intranasal H1 blocker, or leukotriene receptor antagonist. We have to watch these patients. If there is a persistent rhinitis, review the patient after 2 to 4 weeks. In intermittent symptoms, the patient will anyway will get cured within few days. If there is failure, you need to step up the treatment. You have to add or increase the dose of intranasal corticosteroids, or you have to add other drugs. In patients who are having moderate to severe persistent symptoms, the preferred treatment is intranasal corticosteroids along with intranasal H1 blocker or leukotriene receptor antagonist. We have to review these patients after 2 to 4 weeks. You can see it is just like guidelines for GINA guidelines for bronchial asthma. That is when we review these patients after 3 months. Here it is 2 to 4 weeks. If the patient gets improvement, you step down the treatment and continue treatment for more than 1 month. If there is a failure, we need to review diagnosis, whether it is really allergic rhinitis or is it something else, as I discussed in previous slides of differential diagnosis. The most important thing here again is review the compliance, whether the patient is taking the medications as prescribed, especially intranasal corticosteroids. Again, you can see this is comparable to treatment of our patients having bronchial asthma. Query about any infections or other causes. If the patient is not having improvement, you add intranasal corticosteroid if it is not there, or increase the dose. If the symptoms are mainly rhinorrhea, you add ipratropium. If the symptoms is mainly blockage, you can add decongestants, whether it is intranasal or oral, but for a brief period of time as rescue medication, or you add oral corticosteroids short term. Again, this is important. Just like in asthma, it should be a short course steroid course only. If the patient still fails, these patients need a specialist opinion. That is why our ENT people are with us today. If conjunctivitis, we can add oral H1 blocker or intraocular H1 blocker. All the time, try to avoid irritant and allergens as much as possible. So specific immunotherapy is required if the patient is still having symptoms despite the patient is on intranasal corticosteroids, intranasal antihistamines, leukotriene receptor antagonist. So this is again a stepwise approach. One is mild intermittent. Here the patient is just taking oral antihistamines or intranasal antihistamine on their own over-the-counter medication. Step 2 is one of intranasal corticosteroid. These patients are having mild persistent symptoms. So these patients should be on intranasal corticosteroids, which is the preferred treatment, along with oral antihistamine or intranasal antihistamine if required. Step 3 is combination of intranasal corticosteroids with one or more of intranasal antihistamine, oral antihistamines, or leukotriene receptor antagonist. So these are the patients who are having moderate persistent symptoms. In patients who are still having moderate or severe symptoms despite treatment with all these drugs, they should be referred to a specialist. And here we can consider drugs like anti-IgE, which is omalizumab, in severe rhinitis, especially in patients who are having concurrent asthma. Dupilumab is another biological which can be tried in these patients. These patients may need surgical treatment of concurrent pathology. Rescue medications in the form of oral or intranasal decongestants like xylometazoline or anticholinergics like ipratropium intranasal can be used in all categories for a short duration of time. Similarly, oral corticosteroids can be used in severe persistent allergic rhinitis for a short duration of time. Always reassess diagnosis and or adherence and evaluate potential comorbidities and or anatomic abnormalities prior to considering step-up treatment. So definitely we have to rule out other causes like nasal polyposis or sinusitis. The other therapies can be immunotherapy, which can be the mechanism of action is modulation of IgG4 IgE ratio, inhibition of recruitment and activation of inflammatory cells, and restoration of imbalance between Th2 and Th1 phenotypes. So presently available agents are specific subcutaneous immunotherapy or sublingual immunotherapy for different allergens. Monoclonal anti-IgE antibody, as I said, omalizumab, which can complex with free IgE, blocking its interaction with mast cells and basophils and lowering free IgE levels in the circulation. And the drug available is omalizumab, which we are using in asthma also. Neuronal desensitization, saline irrigation, probiotic therapy, intranasal phototherapy, far infrared therapy are other treatments which will be discussed by our ENT colleagues. So this is the mechanism of action of omalizumab. So it will decrease the circulating IgE and ultimately it will decrease the allergic inflammation. About immunotherapy, definitely who should undergo immunotherapy? As I said, patients who are already given all the treatment options, patients are still compliant. They are taking medications, but still symptomatic. These are the patients where we need to start immunotherapy. Review, diagnosis, and check compliance and nasal spray technique, just like in bronchial asthma, when we label them as severe asthma, is important. Symptoms of allergic rhinitis and impaired quality of life despite pharmacotherapy, contraindication or unacceptable side effects of pharmacotherapy. These are the patients who will require immunotherapy assessment. So indications are symptomatic rhinitis to relevant allergen despite optimal drug therapy. So we have to identify the allergen and then we give them immunotherapy. Contraindications are age less than 5 years, significant non-seasonal asthma, concomitant beta blockers or coexisting active disease, and in pregnancy. We have to obtain full informed consent before commencement of specific immunotherapy, whether it is subcutaneous or sublingual. Normal saline instillation, whether it is saline, isotonic, hypertonic, seawater, buffered solution, these are also helpful in relieving symptoms. The proposed mechanisms are mechanical effect, like remove mucus and inflammatory mediators, dilute antigen, mucociliary clearance will be better. There are some proven benefits both in adult and children, and it's a low-cost treatment. The new treatment under investigation or development for allergic rhinitis are pharmacotherapy, the drugs like ABH, which will be available as inhaled drug, MP2902. It's a combination again of antihistamine and steroid intranasal route. Allergen immunotherapy in the form of subcutaneous immunotherapy of recombinant B cell epitopes. Sublingual immunotherapy with grass allergen peptide house dust mite tablet, which could be available in a sublingual form. Intralymphatic immunotherapy with extracts of grass and birch pollen, house dust mites, dog or cat allergen, and administration is by intralymphatic. Omalizumab, dupilumab, I have already spoken about. Dupilumab is anti-IL4R inhibitor, which can be used in a subcutaneous form. Coming to how to deal with failure of pharmacotherapy, patients who are refractory to medical management should be referred to otolaryngologist for considering surgical intervention aimed at providing symptomatic relief. So again, our ENT colleagues will dwell upon this. Most common refractory symptom in allergic rhinitis is nasal obstruction. That is, patient will always complain about that they are not able to breathe. Surgical intervention with reduced nasal obstruction as a means of improving patient quality of life is important. So these are different surgical interventions, that is inferior turbinate surgery, median neurectomy, posterior nasal nerve surgery, septoplasty, endoscopic sinus surgery. Again, as a pulmonologist, I am not very much knowing these things. Coming to last leg of this topic, that is impact of rhinitis on asthma. So you can see first description of hay fire long time back in 1819 by John Bostock, which has written about the beginning or middle of June in every year, a sensation of heat and fullness is experienced in the eyes. That is, there are symptoms of eyes. To this succeeds irritation of the nose, producing sneezing. So nasal symptoms will start, and to the sneezings are added a further sensation of tightness of the chest and a difficulty of breathing, which are symptoms of bronchial asthma. So you can see that there is a link between allergic rhinitis and asthma, both in allergic as well as non-allergic rhinitis. Rhinitis is almost always present in asthma. Rhinitis may be a risk factor for asthma. Non-specific bronchial hyperactivity is increased in persistent rhinitis. So again, by definition, bronchial asthma are patients who are having bronchial hyperactivity. So these are the patients who may be having underlying bronchial asthma also, and we have to look at it. So you can see patients who are having a rhinitis, both atopic and non-atopic, from 10 to 20% of these patients will be having bronchial asthma. Similarly, patients who are having a rhinitis and are allergic to pollen, animal dander, or mite, they are also having bronchial asthma to the tune of 35 to 55%. Similarly, bronchial hyperactivity in a cohort of patients, you can see seasonal rhinitis, seasonal plus perennial rhinitis, they are having bronchial hyperactivity. Ultimate goals of area is to translate evolving science of rhinitis into recommendations for the management and prevention of the disease, to better assess the interactions between rhinitis and asthma, to increase awareness of rhinitis and its public health consequences, to make the effective treatment of rhinitis available and affordable for every patient in the world. The recommendations from area are: patients with persistent rhinitis should be evaluated for asthma, patients with persistent asthma should be evaluated for rhinitis, and a strategy should combine the treatment of upper and lower airways in terms of efficacy and safety. Thank you very much for your patience listening.
So, thank you so much. I think that was an excellent lucid talks, given by Dr. Farmida ma'am and Dr. Gurpreet sir. I think you've really set the ball rolling. Now, what I'll do is I'll just slowly start asking questions, and I would like to give importance to my ENT colleagues first before I start on, two cases which I prepared, and we can discuss each case individually. So my first question, I would like to get Dr. Seemab Shaikh for this question. Now, sir, if you read the brochure that has been spread everywhere, the question is, what is nasal blockage? Now, obviously, in English, we can just translate this as blockage of the nasal cavity. My question to you, sir, is it really so simple, or how would you define nasal blockage?
Thanks, Kapil. Always putting me in the spot to give you an answer, which is very, it's a very broad question that you put across to me. But at the outset, let me thank CCI for having me here again. It's wonderful to be here with all of my chest colleagues, and good reminders of how I've worked with Ravi and everybody else in the past. So when you say nasal blockage, Kapil, see, who defines it, right? On one hand, we have area here telling us a lot of things about. So similarly, who defines nasal blockage? Now, according to me, nasal blockage would be something where the patient is really having trouble with breathing. That is a blockage that I would give importance to. But if I was to define this on a very objective basis, then that would require me to have a look inside the nose with an endoscope, try and understand and see that any nasal cavity which is blocked at least more than, let's say, 50% of the airway, or if I have to put it more technically to the ENT aspects, if there is a blockage of the osteomeatal complex by that deviated septum or an inferior turbinate enlargement. Now, these are blockages that actually require attention, because I think a lot of us probably don't realize, and if you will see over the years, and I'm sure you as well as all chest colleagues will have heard this, that don't do septoplasty, it doesn't work, I've got a nasal surgery done, all recurrence of symptoms. Now that is because you don't assess before doing the septoplasty. Okay, septoplasty is to be done only when this kind of blockage is there. If I was to put it statistically, 90% of the adult population has a deviated nasal septum. Out of that 90%, 10% are severely symptomatic. And out of those 10% that are severely symptomatic, only 4% require surgery. So you can extrapolate this in figures and realize that out of 100, only 3 or 4 would actually require surgery. Whereas it's rampantly being done. And that's where this is coming. So to answer your question in a very short nutshell, only those that are severely impacting the patient's breathing, and objectively, if I'm assessing them with a very bad deviation of the nasal septum, or added to that on a CT scan, I see blockage of the osteomeatal complex.
Okay, perfect. Thank you so much, sir. That was a lovely explanation. Now, Dr. Farmida ma'am, in her talk, she first started with anatomy, and it just reminded me of my anatomy days and how bad I was at it. One of the main reasons why I'm not a surgeon. Now, for nasal blockage, I'm a pulmonologist. So what part of the anatomy of the nasal cavity is important for people like me in my practice to know? And when should I decide to refer to an ENT surgeon? I would like Dr. Abhishek Shrivastava to, just explain on this part. Okay, if Dr. Abhishek is not there, Dr. Seemab, sir, would you like to just take this question?
I'm here. Okay.
Okay, perfect. Dr. Abhishek, sir, please go ahead.
Okay. As far as the anatomy part of nasal cavity is concerned, the main things that we find in our nasal obstruction part is DNS, deviated nasal septums. Apart from deviated nasal septums, we can find some hypertrophy of turbinates that lead to obstruction. So these are the common causes we get in our routine practices for nasal obstructions, and this can be managed surgically with minor surgical corrections. Sometimes the patients do have concomitant polyposis following some allergic rhinitis or other symptoms. They also need to be corrected surgically. They also present with anosmias, partly some decreased olfactions and all that. So these are some aspects of nasal obstructions we see regularly.
Okay, I think Dr. Seemab sir also wants to contribute. Sir, please go ahead.
Yeah, Kapil, see, if, as a chest colleague of mine, unfortunately, you're limited by not being able to see beyond the anterior rhinoscopy. So you don't have the ability, I'm not saying in terms of ability, but you don't have the equipment to see beyond that. So I would say, just like an ENT is encouraged to auscultate the chest to ensure that there's no concomitant asthma, we encourage you to at least look into the nose to whatever extent you can. And you would probably be able to only see the anterior dislocations of the septum, a little deviation and turbinates, right?
True, agreed.
This is maximum that you would be able to see, and then you should obviously ask one of your ENT colleagues to have a look. At the same time, in allergic rhinitis, in the symptomatology itself, we have something which is like runners and blockers, right? So when you're looking at a blocker, I would highly recommend everyone to ensure that that blocker gets looked into a little bit more detail with an endoscope by your ENT colleague.
Okay, perfect. So that was a very good distinction as to when we have to refer to, ENT. Dr. Farmida ma'am, I'll just come to the last part before I go into the case. Obviously, sir has beautifully explained what is nasal blockage and what are the limitations of a pulmonologist. Now, is there more for us to know with regards to the causes of nasal blockage, and what can be the pathophysiology of nasal blockage?
Yeah. So nasal blockage, in case of allergic rhinitis, as I had explained earlier, it can be due to infiltration of the inflammatory mediators into the nasal mucosa, causing edema of the nasal mucosa, leading to nasal blockage. But
Okay.
nasal blockage there can be concomitant other reasons also, as sir and all had described. There can be polyps, there can be a DNS, or in case of any kind of trauma, there might be again DNS or any other reason, or that is what we have to see for in patients with nasal blockage in allergic rhinitis.
Okay. Okay, perfect. At this junction, I would just request my colleague, Dr. Ravi Dosi, if you can just upload the first case, Ravi. I will just quickly go through the case and then we can close it and we can discuss the case.
Is it visible?
Yeah, I can. You just have to do full screen and it is visible. So, for all the audience, we are just discussing these two cases. I will first do case number 1. And once that is done, we will have a round of question and answer with all the panelists and we can discuss this. And then as per the time, I will go to case number 2 and we will obviously repeat the same. So case number 1, next page. So this is a 46-year-old female who is, let's say a resident of Ahmedabad, because that's the city I'm currently in. She's a homemaker, no occupation in the past. She's a complete non-addict, so non-smoker, non-alcoholic. She is an atopic individual. She has got absolutely no comorbidities, so is quite fit for someone who's 46. Although she does have a history of seeking frequent medical advice for non-specific things. She also distinctly gives a history of being punched in the nose. I put that in inverted commas during a fight 2 years ago. Unfortunately, she was not willing to tell me with whom she had a fight. But she also does have domestic issues which are ongoing in her life. So her complaints are she's got frequent nasal watering. She's somehow not able to quantify or something, and I would like to request the panelists later on, obviously, to help me with this term. And she says that the nasal watering is especially on weather changes and exposure to dust. And she feels that somehow things have really worsened in the last 2 years. Of course, please remember, she was punched in the nose 2 years ago and she has got worsening symptoms. She also has got frequent loud snoring, and her husband was the one who came up with this history. The husband apparently is having a lot of disturbed sleep because of this. There's a bit of, nocturnal choking, frequently getting up for urination. She's just generally tired throughout the day, gets up with heavy frontal headaches in the morning. She also has got heartburn. And she says that because she loves sweets a lot, she's occasionally unable to smell them. And she quite distinctly remembers because she absolutely loves gorging on sweets. So clinically, vitals are absolutely stable. Her BMI is obviously on the heavier side. It's 33 kilogram per meter square. Now, nasal examination. Now, remember, this is a pulmonologist who's seeing the patient. As Dr. Shaikh sir mentioned, we are quite limited, but there was some tenderness which was felt, especially on palpating the nasal bridge. So she was not allowing a complete detailed examination, and systemic examination was completely with the normal limit. So investigations, very limited available. So blood work, whatever was done was with the normal limit. So CBC, creat, LFT, everything normal. A chest X-ray was being done, which was normal. A lung function test was done because of her history of atopy, and everything was with the normal limit. So this is the only set of investigations which are available for this patient. So Ravi, I would request you to stop the presentation and we can continue with our panel discussion. Now, first, I would like to get Dr. KP Singh, sir, because sir has been very patiently listening to the entire discussion. Now, sir, I'm going to dissect every line of this case. Okay, now first, we mentioned that she's an atopic individual. what exactly is the definition of atopy, and what do you feel is the history, is the importance of atopy in self and atopic history in family?
Okay, regarding the topic, it's generally been considered and it has been described worldwide that these are the certain sets of the individual who develop allergic reaction on exposure to common allergens or proteins. Somewhere in the Europe, they don't consider it as allergen. In UK, they consider it as even normal environmental protein. On exposure to that, there is exacerbate response to the rise in the IgE level, which is an indicator of an allergic reaction, and the patient often develops symptoms of atopy like hay fever, stuffy nose, rhinitis, itchiness in the eye, dry eyes. So these. Now regarding the family predisposition, it is only 16 to 18% of the, if the single mother or the father are having a history of allergy, then the individuals, then their kids or the are prone to develop, 16% are prone to develop the allergic symptoms. If both of them are involved, then it ranges from 30, I think from 28 to 32%, they are prone to develop the allergic rhinitis. But in the recent data, which was published in BMJ, this is the study which I am talking about. It was published in 2002, and in 1990, the latest data, which is even including the environmental pollution, now says that this risk can be exacerbated up to 44%.
Okay. Those are
So
definitely
that
very
is
high
one of the
numbers.
significant things, and that is of having utmost importance, because these are the quantity of the patients which are very difficult to treat, and you have to use, like Gurpreet sir have already told, that you have to use it at a stage 3, even the inhalation leukotrienes with the low inhalation corticosteroid therapy.
Okay. Okay. Perfect. So I'll just quickly shift to the ENT side. So, Dr. Abhishek, now there was a very funny history which I mentioned. Obviously, this is a hypothetical situation, but there was a very funny history of being punched in the nose 2 years ago. And she distinctly mentions that this is associated with worsening of symptoms. Now, obviously, there is a background of atopy. I completely understand. Everyone will think of allergic rhinitis, but even clinically, she was having a very tender nose. She is not allowing me to palpate in the OPD. So, do you feel there is a relevance of such a history? What will be your thinking, as far as this patient is concerned?
As far as the clinical history or the patient's history, we have to rule out whether she is having a broken septum that has healed in a
Okay.
deviated nasal septum, because
Okay.
she is having snorting and some issues regarding decreased smell. So it has to be taken into consideration that whether that injury has led to a deviated nasal septum, which is causing nasal obstruction. Second is, as far as tenderness is concerned, the history of being punched 2 years back and the tenderness is being persistent for 2 years is a bit fishy. It might be due to some local furuncle in the nasal vestibule, or sometimes it can be some psychosomatic type of feel is there, that the
Okay.
patients who are hyper in their nature, they tend to complain pain on the scalp, on touching and all that. Even they are very sensitive in combing their hairs. So that part has to be taken into consideration. But as far as nasal obstruction goes, and snoring is prominently present in the patient with a normal BMI, then you have to find out some obstructive symptoms by doing some scans of the nose and paranasal sinuses.
Yeah. But actually, the BMI is 33, but we will definitely explore the OSA and the heavy BMI afterwards. But I completely agree. Things do seem a bit fishy, but we will obviously have to explore a lot of angles in this patient. Dr. Seemab, sir, I'm going to give you a very broad question. Obviously, now Dr. Abhishek did mention that there can be a damage to the septum, which will obviously have to be examined. But if I give you a very broad heading, in this particular patient, what should be the surgical approach to the so-called nasal blockage in this patient? What will you reply?
It can't be a very simple answer on this, Kapil, because see, when there is a nasal bone trauma, or whether there's a trauma to the nasal structures, followed by any history. Any ENT surgeon first would like to think of whether you want to make sure that there's no CSF rhinorrhea. Now, in this particular patient, it's a far-fetched thing because it's 2 years, no histories, nothing happening intermittently, etc. So I will just keep that straight away out. The tenderness part, exactly like Dr. Abhishek said, I think again needs to be looked at with a pinch of salt because no trauma can cause tenderness for 2 years. It is not, because the bones would have ossified back again if they are damaged in any manner. So that will have to be looked at with psychosomatic issues. Now, what surgical options remain will depend on what we find inside in the nose. If that deviated septum, like I said, the criteria that I gave you earlier, is really that bad, then only we consider surgical options. If there is nothing out there and the vestibulitis or other issues are causing the tenderness, I don't think this would be a surgical patient from that point of view. And I won't preempt the OSA part, like you said, you're going to come up with it later, so I'll leave that aside for now.
Okay, I think Dr. Gurpreet sir just raised his hand. Probably sir wants to comment or sir wants to add on to the discussion.
Yeah, definitely. I fully agree with my ENT colleagues. But anyhow, if the patient has worsening of nasal symptoms, there was a lot of watery discharge for last 2 years. Anyhow, whether it is related to trauma or not, we should rule out CSF rhinorrhea by doing imaging. So I think we should rule out. It can happen spontaneously also. So definitely, this patient is having a lot of psychosomatic issues that may also cause or may the patient may give this type of presentation. Lot of tenderness is there, not allowing you to examine, but definitely imaging may help. So CT scan or MRI cysternography should be done to rule out any skull base fracture.
Sir, if I may, I would like to just slightly differ on that because I know a lot of people are watching and the message has to be right. I would rather go into more depth of the history of the watering rather than rush into imaging, because if this watering is not giving you that soakage on the tissues or in the handkerchief as we call it, and there's been no real history in terms of any episode suggestive of fever, meningitis, and if it is not necessarily unilateral at one side, so the scope of it being rhinorrhea would be very, very low. The index of suspicion is good to be high there, but I wouldn't really get into imaging until I first start treating the allergic aspect of this patient and see how she responds. Because you're very right when you say that there can be spontaneous fractures that happen, but the history of a CSF rhinorrhea is a bit more characteristic for us to ask for imaging. Otherwise, what would happen was every patient of watery rhinorrhea, if we think of imaging, then that could probably put us in the wrong direction.
Okay. So I think it's a very important fact that Dr. Seemab Shaikh just got. That is the history of nasal watering and all the characteristics. So I would like my next question, in fact, to be on this, and I would like this question to be posted to Dr. Ravi Dosi and Dr. Farmida. So now this patient, I have mentioned in inverted commas, nasal watering. Okay. Now I want Ravi Bhai to first comment on what all will be the medical perspective of, nasal watering. What all will be your questions? How will you ask, to probably differentiate and give a list of differentials. And this will be followed by Dr. Farmida, its surgical point of view. Nasal watering, how important is it? And as Dr. Seemab mentioned, what all tests will you do to get the frequency on? Will you go for investigations and so forth and so on?
Well, thank you, Kapil. As far as nasal watering is concerned, I feel the most common thing predominantly would be allergic symptoms that I would like to look into. And if there are any other obstructive symptoms, gustatory nasal watering is another one very important thing which was mentioned previously in the presentations. So these are a few things which I would strongly like to look into. And apart from the history of watering, additional symptoms like blockage, sneezing, a feeling of itching in the nose, or maybe if they have simultaneous itching or watering from the eyes, any other asthmatic or allergic symptoms like any skin symptoms, respiratory symptoms, that I would like to look into. In children, one history which I would definitely like to ask about is if they pick their nose very commonly, or if they have a tendency of putting things into their nose, because at times that also we very commonly find confounding our allergic history. So I feel these are the few things I would like to ask this patient.
Okay, but Ravi bhai, when you judging by your answer, so you are predominantly thinking of allergic rhinitis. That is what I'm getting from your point
Yes,
of view.
yes,
And
yes.
could you just elaborate a bit more? Pediatric patient, you will ask, history of nasal picking. Why is that so important?
Well, it's very common, they just tend, because that nasal itching is there, they tend to play around in dust quite a lot, and they at time have allergic symptoms with the itching, and they tend to complicate it quite a lot with their habits. So I think I'm sure ENT people can answer this better, because I very frequently see this in a lot of pediatric asthmatic patients I come across.
Okay. So you feel that will just give rise to more trauma and bleeding over
Maybe
there.
at
Okay,
times,
got it.
just day before yesterday, I had a small kid who had some epistaxis with rhinitis. So that time it came out very prominently.
Okay, got it. Dr. Farmida, I'll switch the question on to you. Nasal watering from an ENT perspective, what will be your differentials? And you can probably expand a bit more on what, Dr. Ravi just wanted to say, pediatric patient, picking. If you could just explain all of this.
Pediatric children, they do pick nose when they have allergic pruritus. Generally, what happens is that we in the nasal septum, there is the Kisselbach's plexus, okay, which is
Kisselback. Okay.
so that it's a arterial system which is found in the nasal septum. So when they pick their nose, it is known as the Little's area. So bleeding can occur from that, but rhinorrhea may not be increased because of the pruritus. But of course, pruritus is a part of the allergy which can ultimately lead to bleeding from children. And it is picking the nose in children is a very common cause of epistaxis in children. And this generally don't need any surgical intervention or anything. We can cauterize that area if we see the bleeding point, or if we and then they can be kept on saline nasal drops so that the hydration in the nose is maintained. Bleeding is generally controlled with this. And next, coming to the rhinorrhea part, in this patient, I'd like to ask the patient if when exactly is the rhinorrhea more? When is the watering from the nose more? Is
Okay.
it? Is there any seasonal variation, or is there any diurnal variation? When is it more? Is it outside the when she's out of the house or inside the house, so that we can go towards the causative agent for the allergy. As Seemab sir had already said, we have to rule out CSF rhinorrhea here because it's already 2 years. By now, she would have had meningitis, if at all there was CSF rhinorrhea. So, in surgical point, right now, I mean, imaging and all, even I would not prescribe to this patient. It will be, I'll treat this patient on the lines of allergic rhinitis and try to see what all has happened inside the nose, and try to take a proper history to find out
Okay.
what are the causative agents.
So Dr. Famida, I have got some questions on this. My first question to you is, suppose I'm just giving you a hypothetical situation that this patient says, yes, there is a diurnal variation. That the sneezing symptoms are, let me give you an example, more frequent in the morning hours. What will be the thought process?
So, see, in the morning hours, if it is there and she's inside the house dust mites may be the reason which is giving rise to the sneezing and rhinorrhea. If she goes out and she has it, because pollen grains have this tendency to rise from the early morning towards noon. So, so pollen grains can be one of the reasons. Even if she keeps her doors and windows open at that time, that can also give rise to morning watering. So that is one. That is how we can ultimately go towards the management. We can plan our investigation. If you are planning to do a allergy test, what all we should test. This kind of history comes from that.
Got it. And my second question to you is, and this is just for sake of discussion, let's say she was punched in the nose 2 weeks back. I'm not going to go 2 years back, 2 weeks back, which is a more characteristic
So in
history?
this case, of course, we will have to go for a, CT scan of the nose to find out if there is any CSF rhinorrhea.
But
And
what will be the sort of history and the clinical features of a CSF leak through the nose? Will
it
it be
will be
quantity? Will it be frequency? Will it be color of the secretion? Because I have never seen a patient, so I have absolutely no idea.
it is a clear watery discharge from the nose, and when they
Okay.
bend down, the discharge is more. So,
Okay.
so that they can collect it in a sterile container, and we can send it for CSF analysis or
Okay.
beta 2 transferring test. So that
Okay.
we can do
Got it.
in case of CSF rhinorrhea, and of course, imaging should be done to find out the area of the leak and then plan the surgery accordingly.
Okay, got it. Next I'll just come to Dr. Gurpreet sir. Sir, you had a lovely presentation, but this time, in the history, I mentioned that she is an obese female, BMI is 33, history of loud snoring. The husband, in fact, is quite disturbed by the sleep. There is morning, she's not refreshed in the morning, frontal headaches, generally tired throughout the day. Obviously, I'm hinting towards obstructive sleep apnea. Now, I will first ask you the question, followed by Dr. Seemab Sheikh. Okay. So now, from a very medical perspective, I will tell you my, point of view. I look at a patient given such a history. Probably the only thing that I pay attention to is probably the face. Sometimes, the faces, there is a retrognathia and all of that. If I am in a probably mentally, better, I might probably look at macroglossia, but I'm quite limited with my surgical approach. Do you think we pulmonologists generally must change this about our practice? That's my first question. And second, what all surgical etiologies of OSA do you look for in patients in your practice?
So definitely, this patient is a obese lady with a high BMI. We should look at how her neck is. If it is a short neck, again, it favors towards obstructive sleep apnea. As you have told in the your case, it is a clinical. It is definitely she is having moderate to severe obstructive sleep apnea. Definitely,
Yes.
we have a simple investigation like polysomnography, but as a pulmonologist, when we are doing bronchoscopy day in and day out in our regular practice, we can do nasal endoscopy with our bronchoscope only under sedation and see how the airways are collapsing to document obstructive sleep apnea in our OPD practice also.
Okay.
So instead of doing whole polysomnography, waiting for that, you can easily do nasal endoscopy with our normal bronchoscope. Under propofol, you can just see that these are collapsing. Definitely, when there is a lot of soft tissue in the pharynx, these patients may be candidates for surgical thing so that we can correct it. So our ENT colleagues nowadays are doing a lot of things like ablation, removing that soft tissue from the throat. So if the patient is really having, obstructive sleep apnea by virtue of, endoscopy as well as polysomnography, these patients can benefit from surgical treatment.
Okay. Dr. Seemab, I'll again pose the same question to you. The surgical, because see, there is one thing which generally amongst pulmonologists, we don't pay a lot of attention to it. We are more about BMI, weight loss, sir, as sir mentioned, bronchoscopy, collapsing airways, CPAP therapy and all of that. But, if you could just let us know the surgical approach towards, OSA.
Kapil, I'll give it to you in two different formats. Now, one is, if you were, I don't know how many of you all attended exactly last week's webinar, where I spoke on this very same point, and I mentioned to people about how we should work as a team. And we all have to look into the areas that we can, and because the pulmonologists do have the scope in hand. But Gurpreet sir, I would very strongly suggest that no sedation to be given. You can do the scopy in an awake, lying down, supine position, but never with sedation. That would be one of the most dangerous things to do in these cases of OSA, unless it's in an OT and we are doing DICE. So if you really want to look at this patient, okay, the practical approach that I would do is I would not, and I mentioned this in last week's webinar also, when I am seeing a case of allergic rhinitis, which is so obvious that the symptomatology is there, and there is allergic rhinitis with associated OSA suspected, I would not go in for a polysomnography at this stage at all. I would not go in for a scopy at this stage at all. I would first treat the allergic rhinitis, get those symptoms under control, open up the airway, nasal airway, as much as is possible, because that is going to alter my PSG report, and that is also going to alter the findings of my scopy when I do it later on, because of the Bernoulli's phenomena, because of the pressure changes. If my nose is blocked, my lower obstruction is very different, right? So first treat the allergic rhinitis, then we go into polysomnography. And as pulmonologist, what you're asking me, you have access to the scope, go ahead and scope in an awake, lying down, supine position. But the problem is, your mind will not be able to analyze what you are probably not able to see and correlate. And for that, you need to be very, very well trained in what to look for. So just seeing the collapse is possibly not good enough. So the practical point of view is, if you want to get into that as a sleep apnea thing, then you need to know what structures are collapsing, how much are they collapsing, and what you need to remove. But clinically, you are, very, very able enough and competent enough to see the oropharynx. You're competent enough to see the size of the tonsils. You're competent enough to see whether in the nasopharynx there's any adenoid tissue, which is very much there in adults also in today's date, not just in pediatrics. And you are very much competent enough to see the collapse of the epiglottis. And that is one thing which I very, very strongly advocate everybody to take a look, because as a pulmonologist, you are going to prescribe CPAP or you're going to give a CPAP trial. But if you're having that epiglottis which is collapsing and you're going to give a CPAP from above, your trapdoor is going to shut and suffocate that patient more. So kindly do not even think of a CPAP trial unless you or your ENT colleague has had a look at that epiglottis. This is something I'm strongly advocating across the country, wherever I speak, whenever I speak.
Perfect. So many points for us to, understand.
If there was no shortage of time, I could have pulled out that video and shown you how the epiglottis collapsed, but we'll keep it for some other time when I'm giving a presentation.
Yes, Dr. KP Singh, sir, you raised your hand. Yes, please. Sir, you are muted. Kindly unmute yourself. Yes, sir.
Yeah. So actually, I want to say one thing regarding my experience with the bronchoscopy. I am doing quite a generous number of bronchoscopies. Last year, my data was around about some 860 to 900 bronchoscopies a year. So I am doing in very obese patients also who are 140 kg, 130 kgs, 90 kgs. So what I have encountered a practical problem with those patients who are on OSs, the number is very few, around about 15 to 20 patients I have done. First problem is we cannot make them lie absolutely in a supine position because they tend to develop hyperventilation. First thing. Second thing is I just try to do them up in a slightly raised position, approximately 30 degree. I take it 30 to 40 degree, and that works wonder. Second thing is I try to use a sedation, but I try to give them a mild sedative like a ketamine, small dose, not very adequate to make them sedate, but that is there to give them awake. Because if I sedate them for a long period, even if I completely sedate them with the propofol, what happens is the most of the upper airway, they tend to collapse and it becomes difficult for even the bronchoscope to negotiate at a time. But I found it in my personal experience to be difficult. And secondly, then these patients go into a complete airway collapse of the upper airway. And that is the most difficult thing. Second thing, I think Dr. Shaikh has specifically pointed out, what happens is most of the adult population who is even on the borderline obesity, I should say BMI between 29 to 32 or 27, even about 27. Most of these patients I am finding adenoids. I don't know why, but During my undergraduate days, I used to learn that adenoids mostly confined to the children's. So that was a point which I have learned, and that has even come out from the Sheikh's vocabulary. So three things, and regarding the OSA patient, one must keep a watch as a pulmonologist while doing a bronchoscopy. Keep a good suction ready, and mouthpiece ready when you're doing all this procedure, because the tongue falls to fall back in absolute supine position. So that is one of the reasons. So these I am.
Kapil, may I just add on? It's a wonderful point that sir has brought out. If you allow me to, I would like to put on.
Sure, sir. It's a pleasure learning. Every day is a learning in the medical field.
Absolutely.
Sir, I think 2 minutes for your comment, because we're already, it's already 9:20.
Absolutely. If you allow me to, others, we
just
can
2 minutes. Just 2 minutes, so you can quickly
I will quickly make those points. Sir, adenoids in adults, remnant adenoids has become a very big thing, which we are trying to make people understand, definitely. Secondly, I think we must differentiate that when you are using your bronchoscope, are you doing a bronchoscopy, meaning are you going through the cords down into the bronchus, or are you just using the scope just to see the collapse of the airway and your way supraglottic? So if you are supraglottic, then it is really not advisable to use sedation without the presence of an anesthetist.
Exactly. That is what I do. Even when I'm using a small dose of ketamine, I don't use it with my own hand. I put my anesthesis on the work. That is, and I do it on OT for these patients.
Perfect. That is a very important point.
That is important because I see, because I run my own private hospital and we cannot afford things like going into pitfalls. And second important thing is, even a small anesthetic like ketamine, which we can even use, but I appoint an anesthetic to do that job.
Absolutely.
Because see, there are pitfalls to this, because most of these patients have sudden cardiac arrest. If you go by the history and everything, but 30% of the patients who have OSAs and are morbid obesity, 30% tends to develop sudden cardiac arrest. So any dose of anesthesia, any dose that regulates with that increases the intracranial tension, cardiac pressures, and all those things should be used wisely and should be done in a supervised way.
Okay, right. I think I will
that point out was, sometimes there are a lot of our junior colleagues, PGs watching this, and they may rush into this.
Exactly, I agree.
Very important to.
Okay. I will just allow me to come in. I think I'll need to intervene over here because we are running short of time and we need to go ahead. So I'm sorry, but we can definitely have this discussion later. And Dr. KP Singh, sir, I will just like to get you in on the panel right now, and I'm going to ask you a combination of two questions. Okay. In the case of first there was a line in which said, she was having heartburn. Now, as a pulmonologist, we know that reflux it's the bane of, it's like a silent killer for all of us, COPD, IPF, I see it post-transplant. It's really quite bad. So my first question to you is, do you think GERD is also important for nasal issues? That's my first question to you. And second is, we saw that, obviously she's a female. She was having domestic issues, probably punched in the nose, somatic complaints, frequent visit to the hospitals for non-specific reasons. So would you agree that there seems to be some sort of a psychological etiology of this? And do you see that quite often? So these are my two questions to you.
Okay, let's answer me the first part altogether. So every time there's a sneezing, this tend to lower the lower esophageal sphincter pressure.
Okay.
And that is the keyhole of GERD. Point it out simply. So even if the GERD is the most common cause, GERD can always precipitate allergic rhinitis. Also, it is vice versa vicious cycle also. That has been documented. Right?
Okay.
So part of the question is over. Now let's deal about the second part. Since there is a history probably of her, we can think that probably it is domestic violence, and even her husband when complains that he is not tolerating it well with the snoring. So probably we can speculate out that the things are not going well. And these patients we do encounter, but these patients come out from a very low socioeconomic background, middle-aged background. And even if we go into the detail of the history, there's some or the other thing we always find out. Why these patients, not only I encountered a lot of males also these days, These patients comes on with a frequent history of shy breathing syndrome. If we go back in our UG and PG days, there was a line written in Harrison, shy breathing syndrome, that they said that they get hyperventilation. That was a part of a shy breathing syndrome. So there must be a somatoform disorder with these patients and the psychological impact to it, and that is how these things persisted. And what leads them to coming down to the people again is because any amount of antihistamines produce mild sedation, so that gives them a slight relief.
Okay.
But these patients, there was a study in UK, these patients who are more prone to use this antihistamines and leukotriene inhibitors like Montelukast, like Gurpreet sir has always said that it comes with a black box warning. So probably they land up into those categories. And if you follow them over a period, they mostly land up into either depression, manic, and borderline schizophrenics. Because every time they just try to justify their symptoms with the medical terms, otherwise not realizing what's happening at the psychological end.
Okay. Okay, perfect. So I'll just not able to see Dr. Abhishek on the panel, but anyway, I'll just the last question for this case before I move on to the next. Dr. Farmida ma'am, anosmia. Now, as a pulmonologist, whenever I hear the word anosmia, I'm afraid, can there be a neurological issue, which, I have met? So is anosmia definitely only a neurological issue, or do you feel that every rhinitis can present with a degree of anosmia?
Every rhinitis, of course, will not present with a degree. I have not seen in my patients at least. But of course, long-term rhinitis with edematous mucosa of the nose, where there is breathing difficulty, they do sometimes complain of hyposmia, less perception of smell. And when a patient comes to me with anosmia, first I physically examine the patient. There might be a DNS causing the anosmia, DNS, or in case of polyposis, the patient may have anosmia. So these things has to be ruled out. Only after that we'll think about neurogenic causes, and of course trauma. In this patient, the patient had trauma. So trauma to the olfactory region can lead to anosmia in this patient. And anosmia as such, it can, if we treat the underlying cause, the polyps or the DNS, that will, the smell perception will return with that. And neurogenic, that is a completely different thing altogether.
Okay, perfect. Okay, so thank you so much. That was, I'll just conclude case number 1. Ravi bhai, if you could quickly put case number 2. I'll just go through case number 2 and once again have, a discussion. And just a word, to all the panelists. I think we are quite short on time. So I'll just be sort of merging questions for case number 2. And we'll have a very quick, discussion, and we will go through the questions quite quickly. There you go. Okay, perfect. So this is case number 2 quickly. So this is a 46-year-old male resident of Mumbai. He's a mill worker, no comorbidities, is an occasional smoker, insignificant smoking index. Again, even this individual is atopic, and there is a very strong family history of atopy. Next page. So the complaints are there is a dry cough, which is on and off since many years. Occasionally, there is breathlessness. He does not exactly, ratify the breathlessness, but this is associated with wheezing. Now, again, this patient mentions that there is persistent nasal watering, and he uses Vicks inhaler and VapoRub, and he, has got symptomatic relief. Examination vitals are bang normal. There is a very mild supraorbital foramen tenderness. And respiratory on auscultation, there is bilateral wheeze. Systemic examination is normal. As far as investigations are concerned, so CBC shows 8% eosinophilia. A chest X-ray done was normal, but the PFT is quite clearly there is a moderate obstruction, and there is a good reversibility of 140 ml and 20%, and the FEV1 is 54%. So management point of view, now this is what the management was started by the treating physician. So steam inhalation thrice a day, There is no comment on the Vicks inhaler and the Vicks vapor, but I will definitely take it up with my esteemed panelists. MDI Foracort has been mentioned, which is ICS plus LABA. 200 is the dose, once in the morning, once in the evening. And tablet, a combination of Montelukast and fexofenadine has been given once a day, and this is for 10 days. So this is all the management which has been given. Thank you so much, Ravi bhai. You can close the screen. So Ravi, I'll start with you. Generally, whenever we talk about bronchial asthma, rhinitis, all the pulmonologists have always been taught one airway, one disease. Okay, because obviously the airways start right from the nose. So my question to you is, do you actually believe that this is true, or because we have our ENT colleagues over here, do you believe that problems of the nose is best handled by them and we should only focus on the lungs? What is your outlook?
Well, very, very controversial question, but we are 3-3. I think we balance out each other. So I strongly feel it is a unified airway disease.
Okay.
And if we have eosinophilia in a patient, particularly like you have mentioned in this case also, then there is a strong argument in favor of using steroids by us for our asthma part, and the same part we can use for the rhinitis part also. So as far as unified airway disease is concerned, allergy, if that is the etiology, then definitely we can manage it as good as anybody. But definitely, like I think Seemab sir very well outlined the percentage of cases. There is a very, very limited percentage of cases in which we need to understand that it is not allergic and there is something else at play. That is what warrants a proper ENT evaluation and further management.
Lovely. Okay, perfect. Okay, now, common question. See, now obviously we are pulmonologists and ENT colleagues. We obviously have got quite a different practice and patient base, but I feel allergic rhinitis is something which might overlap. So, I just want to understand a very general question to all the panelists. What is the percentage of, allergic rhinitis which you basically encounter in your, practice? So first, the pulmonologist. So all of your bronchial asthma, do they come up with allergic rhinitis, or do you feel that only hardly 10% of them have allergic rhinitis?
No, in my practice, it ranges from 30 to 40% of the patients are having allergic rhinitis along with bronchial asthma. So
okay,
it's quite common.
Okay, and KP Singh sir, आपका भी it's the same, or do you feel it's different?
Same. और अभी तो क्या थोड़ा बढ़ गया बल्कि.
You feel it is, yeah, because in the north, yes, we do understand that, so it has increased. Ravi bhai?
Sir, very high, very. I would say 80% of my asthmatics have rhinitis, and even if they don't have concomitant rhinitis, they will always have a history of having it once or the other time in the past.
Okay, and what about my ENT colleagues? Is the number as high, ranging between 40 to 80%, or do you feel that you see much more infectious and vasomotor and all the other types of rhinitis in your practice?
30 to 40%, I would say. I mean, from my practice that I see allergic rhinitis. Yeah, certain of them are overlapping with vasomotor rhinitis like that. And yeah, we do also see infectious rhinitis.
Okay, and Seemab sir?
Yes, I think the figures are matching with almost everybody. It is generally in the range of about 40 to 50%. And
okay.
I would, to answer that part about where you said that why shouldn't you look into that? You should. I mean, it's obvious that when it's a simple allergic rhinitis situation where there's not so much of a blockage issue, there is no reason why a pulmonologist should not look into the allergic rhinitis along with the bronchial asthma.
Okay.
At least in the initial part. And if you find that the nasal symptoms are not resolving, then obviously. And we have to be a little practical. You can't have the patient in private practice running from here to there just because there's a different specialty.
Got it. Dr. Farmida ma'am, in your presentation, there was a point in which you mentioned local allergic rhinitis. Could you once again just specify what exactly? Could you just explain that once again?
Yeah, so local allergic rhinitis is it is a kind of rhinitis which does not have a systemic atopy. If we go for an allergic test, you will not get, if you go for a skin test, suppose, you will not get any allergens specific to that allergy. But there is allergic reaction local to the nasal mucosa. So if we go for a provocation test where we administer saline buffered allergic agents into the nasal mucosa and keep increasing the dose, at one time we'll get sneezing or rhinorrhea from the patient. And if we see that cytology of the patient, we will see that there are inflammatory mediators there in the nasal fluid. So this is one entity, but later on it can develop into allergic rhinitis.
Okay. Okay. So, Dr. Gurpreet, sir, I would like to definitely get you in on this. You had an excellent presentation on area guidelines. It's a topic which we don't pay a lot of attention to, although we must. But, when a patient comes to you for nasal watering, and I'm specifically asking you this question, we might be having a lot of young pulmonologists and especially students looking at, this. How should we break this, history of nasal watering into simpler parts just for classification purpose? And why is it important to classify allergic rhinitis?
So definitely, when the patient is having symptoms of rhinitis, whether it is congestion, nasal blockage, or watering, first thing will come into our mind will be allergic rhinitis only. But definitely, we should rule out any other cause of their rhinitis. So it is important to ask for history, any occupational history, any exposure to allergens. So that is very, very important. Whether the patient is using any kind of medication, NSAIDs or beta blockers. So these are very, very important to rule out any other differential diagnosis. A patient who is having bronchial asthma along with nasal symptoms, and if we are sure that this is allergic rhinitis, they should be treated along with bronchial asthma in the form of intranasal corticosteroids, plus minus antihistamines, which we regularly do.
Okay. And Dr. KP Singh, sir, you mentioned that, right now you're having a lot of cases of allergic rhinitis. So this guy also was a mill worker, the case. So what is the importance of occupational history in such atopic conditions and especially with allergic rhinitis?
See, most of the patients who is like what you have told, probably you are pointing out to the allergic source in the occupation. So these patients who comes down with such a occupational history, they either tend to have an exacerbation of the symptoms, or we have to ask them, particularly in the history, whether the symptoms have increased after getting into this occupation, or when there was a long holiday away from the occupation, does the symptoms get released, or there is a decline in the intensity of the symptoms. So probably that will help us knowing about the trigger factors that has been involved in that occupational area. Because but there is not much of recommendation that has already been mentioned by Gurpreet sir in his talk, that it is recommendation D, away from the allergens. When it has been developed, and we can always we have to treat it and we have to take care of it. But I wonder one thing, that if repeated exposure to certain allergens is taking place, and we know that has precipitated the things like allergic rhinitis, I am not able to find it answers to it. But what I feel is, once you make them escape out from that location or a pollutant environment, or a place where there are number of weeds or other particles that have precipitated the allergic rhinitis, probably that will help them off in tapering the pharmacological drugs needed to control those symptoms and lead them to a near normal life.
Okay. Okay, I'll again get Dr. Gurpreet sir back on the discussion. Sir, in your topic, in your presentation, you mentioned about a visual analog scale. Now this is a more of a personal question. I feel that these scales sometimes have got a lot of subjectivity. So are you still comfortable with the fact of using a visual analog scale? Do you feel sometimes we can over or underestimate the burden or the severity of the disease? And do you feel it needs to be replaced with some questionnaires or something like that?
If we see a visual analog scale, the advantage is basically that you have to spend little less time on the patient in your busy practice. So that is the advantage. But otherwise, definitely, as you said, a list of questionnaire will be giving us more insight about the patient's symptomatology, because the symptoms could be a nasal congestion, rhinorrhea, nasal obstruction, too much of watering. So all these things have to be combined into that scale, and that gives us a picture about how severe the symptoms are. Yeah, so the advantage definitely could be the patient sitting in your waiting area can just fill that visual analog scale, and you can be knowing how much symptomatology the patient is having and how much improvement is from the previous visit after you have given treatment for say 2 to 4 weeks.
Okay, perfect. Okay, so now I would just like the next 5 minutes of the discussion to go towards management. And management, I would like to get Dr. Ravi Dosi as well as Dr. Seemab, sir. So first, Dr. Ravi, when would you decide to, manage or start treatment of allergic rhinitis? Sometimes do you feel this is self-limiting? And what will be your choice of drugs that you would like to begin with? If you could explain that to all of us.
Well, if the patient is presenting to you in OPD, then definitely I think that warrants in itself enough severity to start treatment. Now, if there is a regular history of more than several times in a week that the patient is suffering from it, and he's having this symptoms predominantly affecting his lifestyle, his sleep, or even his work, then I would start treating him with inhaled corticosteroids, intranasal steroids, and also identify whether his nose is, how is the nasal hygiene, whether the nose is properly hydrated or not. And apart from that, definitely I would like to look at the chest part. If he is having any systemic eosinophilia or high Ig levels, at least once in the duration of his treatment, I would like to have a look at his eosinophil and Ig levels, and would like to treat that with systemic steroids if needed.
So suppose this patient does not have bronchial asthma, suppose this is only allergic rhinitis. And let's say the eosinophilia is let's say 8%. I'm just giving you a hypothetical situation. So would you still be, so you will just restrict to treatment of the nose, right? That is what I understood from your answer.
Yeah, definitely. Means, see, it depends on severity. Also the fact that intranasal corticosteroids offer very good relief in patients with some amount of eosinophilia, because again, it is the Th2 inflammatory pathway which comes in, and they are very excellently steroid responsive. So I would treat intranasal steroids.
Okay, got it. So intranasal corticosteroids will be your approach. Dr. Seemab, sir, I mean, apart from the intranasal thing, do you think that oral medications, we very commonly, we have got this combination, sometimes plain Montelukast, sometimes Montelukast plus levocitrazine, sometimes we've got, and now recently, we've got bilastine, fexofenadine. So what is your thought process on all these medications?
So pharmacologically, if you go to see, none of them seem to have an added advantage with a combination. I think the jury is already out there on that. So besides the earlier, earlier arguments towards combination therapy of compliance and things like that, I don't think there's any added advantage to having them together. Okay, that's the first thing. I think most of them are best given separately, and a little bit of compliance has to be taken into it. We very strongly would follow the area guidelines. In fact, we have written down the allergic rhinitis guidelines for India for the ENT Association. It's out there on the website, and I'm honored to have been a part of the team that wrote that guidelines. But the basic following is not to reinvent the wheel. So the persistent or moderate severe persistent disease and the intermittent to persistent timing, so the time and the severity would decide the use, and always intranasal corticosteroids in the severer part or moderate to severe and the persistent variety. The minute you get that from your history, the first line should be intranasal corticosteroids.
Got it. Okay. Okay.
Along with that, obviously, you will add your antihistamines. And if you want to add in the anti-leukotrienes, I would always prefer to give it as a separate tablet. You can even spread it, because prefer to have an antihistamine in the morning and an anti-leukotriene in the evening, so that you have the time gap for the late reaction to happen.
Okay.
And only one point that I would just quickly mention is about this black box warning. I think, I don't know, I would like all of y'all to actually give me an opinion. Whereas, are we not overplaying this black box warning? I'm not saying that it's not to be looked into, and I'm not saying that we should not be aware of it. But consider the amount of Montelukast that has been used for. Yes, sir, please. I would like to have your opinion on that black box warning.
So to be honest, actually, I have been using approximately, I got 3,000 registered patient in a year for allergic rhinitis, and I've been using leukotriene.
Wow.
Except for having a mild sedative effect, and few patients from a lower socioeconomic group, 80 to 90% were female, who are having already a predisposition to the psychological effect due to their surroundings. I think I haven't encountered any till date, and 3,000 is a good number. To be very honest, I'm playing it straight.
My point exactly, sir. My point exactly, that I think the black box warning needs to be taken with a little pinch of salt.
Little pinch of salt, but I got one question towards it. The FDA hasn't warned us about the maximal dose at which this black box warning takes place. Any literature I have gone through, it does quantify the amount of the drug.
Absolutely, sir. That's the point.
Is the problem.
That was the point. But I would definitely say, in pediatric age group, be careful. In an adult, I think take it. I'm not saying you don't be aware of it, but I think we're giving it too much of importance in black box warning. Because otherwise, also, if you look at it, our use of Montelukast is maybe a month or 2 months, 3 months at a stretch. We don't tend to use it for years together or many months together. So I feel using that in a separate combination with the antihistamines makes a lot of sense. But my first line choice in a moderate severe persistent variety would always remain the steroid sprays.
Okay. I have a question. What is the maximum permissible dose have you seen in children? Or
no, sir. Absolutely not. I'm not aware. That is the reason I mentioned this point.
I haven't came across any literature.
Yes. That is the reason
that is the problem. So I think this question is open to the panelists to consider.
I wanted to bring in this point for that reason only. We all need to think over this. We have this fad of, okay, this black box warning is given. Everybody wants to get on Montelukast. We are sending out a wrong message to the youngsters. But at the same time, we are saying this with a word of caution that do not overuse it.
Let the youngster even try to learn it from the guidelines, like what we learned from our guidelines. Since this is a black box warning, it's okay. But what was the dose? They haven't. The FDA hasn't approved any higher doses limit to it, and neither the duration they have framed it up. But I think 3 or 4 literature have mentioned it using beyond 3 months to 120 days. They have mentioned there are some psychological effects. That's it. And I think none of us are using for that long period. 120 days is a big amount of a period, sir.
No, sir. I just want to add one thing. As far as being prescribed by a proper allergy specialist, ENT person or chest physician, it is fine. But so many people come that they are even using combination of Montelukast and antihistaminic as a OTC drug. They जब होता है तब जाके ले लेते हैं, आराम पड़ जाता है. So I think that is one thing which should definitely be मतलब it is not justifiable. I don't think it is an OTC.
I think OTC has always been a problem in our country. A lot of drugs are available over the counter. This has definitely obviously been an issue. Yes, Dr. KP Singh, sir. Yes, go ahead. And then, I would like to...
The message should be from this platform should be that these drugs, if the patient has been taking them from the OTC, should be notified in your history for how long has he been taking and what was the amount of the drug he has been taking.
Okay. So, I
think that will give a wonderful line to youngsters to how to even recapitulate the history, because most of them are OTC or the RMPs or the general practitioners are using. So let's define it, because that will also hamper the underlying treatment guidelines also, to be honest.
And I think what Dr. Seemab sir said also, we have to look at our indigenous guidelines also, in which he's been a part of. There is something which definitely we need to pass this on to a lot of the people. But let's come back to the panel quickly. Two questions before we wrap up. First is to Dr. Farmida, the role of allergy testing. Now, I must mention that I am a bit of a skeptic, but you can definitely prove me wrong. So do you think that allergic testing is a very important part, in evaluation of allergic rhinitis?
No, see, we can always come to a diagnosis from history itself. And we have to look into the perspective of a mill worker, as you had said in that case. We have to also look into the perspective of the financial status of the patient. So all these things we have to consider, because if we do an allergic testing, are we planning to go further and do administer immunotherapy also? That we should always keep in mind. So allergic testing per se, I don't do in my patients in the first go itself. Only if the patient is not responding to any pharmacotherapy, then he is a refractory case. Only then I think about doing an allergy testing. So then we can go for skin prick test, because that is the gold standard, and we should plan further, go into allergen immunotherapy or something. But if you're not doing that, in some certain cases, just to tell the patient that, these are the things you're allergic to, you can avoid them if they're avoidable. Then maybe we can go for an allergic testing. But in many patients who are financially not that this thing, I try to stick to pharmacotherapy, try to delay allergy testing as much as possible. As for other like total IG and eosinophilia and all those, I have read in certain literature that they are present. I mean, they can be present also in Indian population. They can be there in other conditions also, maybe parasitic infestation and all. So even that I don't do very regularly. Mostly I rely on the research.
But when you do your immunotherapy, you see a lot of positive results. Is that what I understand?
I have done very few, because my allergy practice has started only 2 years back. So I can't really comment on that. I think the seniors, Dr. Ravi, Dr. Seemab sir, will be able to tell that.
I think, Kapil, the word that she's used is very important, refractory. Patient refractory to treatment, whether he's from your own treatment, or roamed around the whole city and different cities and taken so much and then come to you very frustrated. That is the person I would think towards immunotherapy and then a skin prick test. One has to be practical. If the guy is coming to you maybe 1 or 2 times, he's taken treatment and come, and he's probably not followed the protocol, then I think I wouldn't do it in those initial patients. I would do it in the refractory cases.
Got it. Okay. And my last question before I wrap things up is directed towards Dr. Ravi. Ravi bhai, India is a very diverse country. Okay, we have people using traditional methods. You've got your jeera and ajwain, which is heated, mustard, which is heated, Vicks vapor up, Vicks inhalers, everything. I have personally used it. I even like it. I'll be honest and I'll admit this. But what do you think? Do you think this should be encouraged? Do you think this should be looked from a different perspective? Or do you think we should completely be non-committal to it because we don't know if it works or not? What is your thought process?
Well, before I answer this, Krishna sir has just informed that there are around 882 people watching us all over India for this webinar. So a big congrats.
Excellent.
So, well, yours is one of the most beautiful questions. You see 30 patients and out of 30 patients, 30 them and 30 attenders are already using Vicks Superab and everything like that. So nothing against it. It is excellent. But I feel if a patient is suffering from rhinitis, the use of these things delays presentation to a specialist. And routine mild things for 3-4 days, viral and all, you use it, it's okay. But I think if it is going on persistent, related to seasonal thing, more than 7 days, severe, then definitely this cannot be justified. They should have a statutory warning on these things. कि अगर ज़्यादा है तो you go and show to a specialist. Then only it is justified.
Okay, perfect. Okay, so with that, I would like to get this entire panel discussion. I would like to close this up, and I would just like to summarize. I started off as quite a skeptical person, having absolutely no knowledge, but I deliberately chose to be the moderator because I did not want to be in a spot. But I think this is extremely lovely of all of y'all to contribute in so many ways, so many things which we have understood. We started with Farmida ma'am's presentation, the anatomy, the causes of rhinitis. Gurpreet Bhai really took over, area guidelines and overview. We saw so many possible causes, right from surgical to traumatic to GERD to obstructive sleep apnea, to psychosomatic to neurological, especially anosmia. There are so many ways in, just looking for nasal blockage. And, we obviously, this was followed by a very quick discussion about allergic rhinitis with area in focus and all the practical aspects which came because of the experience and expertise of my expert panelists. Very important take home message also is that we do have indigenous guidelines of allergic rhinitis, and everyone should definitely go ahead and research this and be a part of this. Thank you so much, CCI, Dr. Krishna sir, Dr. Vijay Kumar Chenam Chettibai, Atri, Anil Maske, Ashish Dubey, so many people working behind. Thank you so much to my esteemed panelists, Dr. Seemab sir, Dr. Farmida ma'am, Dr. Abhishek bhai, Dr. KP Singh sir, Dr. Gurpreet Singh sir, and finally my brother, Dr. Ravi Dosi bhai. Thank you so much, all of y'all. Long live CCI. Thank you so much.
Thank you
Thank
very
you,
much.
Kapil. Wonderful moderation, Kapil. I must compliment you. Very well taken with the flow. Very
Thank you.
pertinent questions
Thank
which
you,
have
Dr.
brought out the right points for the right everybody. Thank you so much. Wonderful
Thank
being
you.
with all of
Take
you.
up, Kapil. All the best in the coming years.
Thank you.
Good night.
Thank you.
Good night, everyone.
Good night.